101 of the House of Commons Standing Committee on Health. Today's meeting is taking place in a hybrid format pursuant to the standing orders. Just a few comments for the benefit of members and those participating online. You have interpretation available to you on Zoom. You have the choice at the bottom of your screen of either Floor, English, or French. For those of you in the room, you may already know this. You can use the earpiece and select the desired channel. For those online, please bear in mind that screenshots or taking photos of your screen is not permitted. In accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. Pursuant to Standing Order 108 Sub 2 and the motion adopted on May 16, 2022, the committee is resuming its study of women's health. I'd like to welcome our panel of witnesses and thank them for their patience while they awaited democracy to run its course so that we could be here. Appearing as individuals, Dr. Gillian Hanley, Associate Professor, Department of Obstetrics and Gynecology at the University of British Columbia. Dr. Hanley is appearing by video conference, as is Dr. Jessica McAlpine, Professor and Division Head, Division of Gynecologic Oncology at UBC. Representing Ovarian Cancer Canada, Tanya Vrionis, Chief Executive Officer, et Valérie Dain, Directrice Régionale du Québec. Representing the Society of Gynecologic Oncology of Canada, Dr. Shannon Salvador, President-elect. Thank you all for taking the time to appear today and for being generous with your time and awaiting our arrival. Each of you will have 5 minutes for an opening statement, and we're going to begin with you, Dr. Hanley. You have the floor. Not this Dr. Hanley. No, you'll get your turn. Dr. Gillian Hanley, you have the floor.
Bonjour et merci beaucoup pour l'invitation.
Thank you for the invitation to speak to you today.
I am an associate professor in the Department of Obstetrics and Gynecology at the University of British Columbia and a Tier 2 Canada Research Chair in Population-Based Gynecologic and Perinatal Outcomes. I am also a member of the Gynecologic Cancer Initiative, along with Dr. McAlpine. The GCI is an interdisciplinary network of patients and family partners, clinicians, and scientists who are all working across gynecologic cancer disease sites, across institutions, and across disciplines, with the goal of reducing death and suffering from gynecologic cancer by 50% by 2034. This is an important goal, as this year alone, 12,000 Canadian women, transgender men, and non-binary people will be diagnosed with a gynecologic cancer. Gynecologic cancers include cervical, endometrial, vulvar, vaginal, and ovarian cancers, and represent 10% of cancer deaths in women. Importantly, funding for gynecologic cancer does not reflect this disease burden. The Canadian Cancer Research Alliance calculated that there was a 60% higher investment per case in breast cancer research compared to gynecologic cancers. This disparity increases to 270% higher investment in breast cancer when the numbers are based on cancer-related deaths. Thus, both national focus and dedicated investment are needed in this important area. Despite these challenges, Canadian researchers have made important strides in understanding, treating, and preventing gynecologic cancers. There are many areas in gynecologic cancer where Canada is world leading, including in ovarian cancer prevention, where my research is focused. Despite tremendous international effort, there is no effective screening method for ovarian cancer. Symptoms generally do not arise until the disease is in advanced stages, where 5-year survival rates are well below 50%. Thus, we have focused our efforts on preventing ovarian cancer. There are 5 distinct types of ovarian cancer, and 70% of ovarian cancers and 90% of deaths from ovarian cancer are from the high-grade serous type. Approximately 20 years ago, we discovered that most high-grade serous cancers arise in the fallopian tube and not on the ovary, as was previously believed. Fallopian tubes connect the ovaries to the uterus, but they play no known role post-childbearing. This is not true of ovaries, which produce endogenous hormones that are important for women's long-term health. thus taking the opportunity to remove the fallopian tubes during other gynecologic and pelvic surgeries while leaving the ovaries behind has been a groundbreaking ovarian cancer prevention approach. In 2010, our team in British Columbia launched the world's first population-based ovarian cancer prevention program. We recommended that salpingectomy, the removal of both fallopian tubes, be performed at the time of hysterectomy, the removal of the uterus. We also recommended that fallopian tubes be removed instead of ligation or having your tubes tied for permanent contraception. Recognizing that approximately 80% of ovarian cancers occur in people who have no genetically increased risk, this prevention effort is not based on risk for ovarian cancer, but rather on opportunity. Hence, we called it opportunistic salpingectomy. We are taking an opportunity provided by another surgery to also conduct this important ovarian cancer prevention strategy. This is now recommended practice in 9 countries worldwide, including in Canada. Through research, we've demonstrated the safety and feasibility of opportunistic salpingectomy, and in 2022, we provided the first evidence that removing fallopian tubes does significantly reduce risk for ovarian cancer. Despite these compelling data, a recent assessment of pan-Canadian practice of fallopian tube removal demonstrated considerable variation in uptake outside of BC. The study estimated that between 2017 and 2020, nearly 80,000 Canadians received a tubal ligation or hysterectomy without fallopian tube removal, missing an opportunity to stop ovarian cancer from developing and translating to a possible 1,000 future cases of ovarian cancer that could have been prevented. My recommendations today are to increase the funding for gynecologic cancer research to accurately reflect the burden of these cancers on Canadians, and target funding to groups which are multidisciplinary and working across cancer disease sites and institutions to make the fastest and most meaningful progress. We also recommend a focus on funding for implementation science to ensure that important research advances are available to all Canadians, and that the federal government consider engaging in communication strategies targeted to patients and clinicians to help get these important research advances to all Canadians. Thank you very much.
Thank you, Dr. Hanley. Next, Dr. McAlpine for 5 minutes. Welcome to the committee. You have the floor.
Thank you very much. Thanks for the opportunity to be part of today's session. I'm a surgeon scientist and professor at UBC. I spend half my time in surgery and seeing patients with gynecologic cancers and half in translational research. So you have heard and will hear more from my colleagues about the disparity of funding for gynecologic cancers. I'm extremely grateful to federally supported funding initiatives such as the Canada Research Chair and institutions like CIHR, without which many of the discoveries you'll hear about today would not have been possible. However, the competition for research funding has soared, and actual funding available, in particular for multidisciplinary team projects and clinical trials, is increasingly difficult to obtain. We're at risk of losing our reputation in Canada of being innovative, creative leaders, changing the landscape of gynecologic cancer care. And we're at risk of appearing irrelevant if the scientifically validated initiatives that we do generate are not actually implemented and delivered to Canadians in a timely fashion. I'm going to share one example of proven research advancement, homegrown in Canada, where we need to do better about ensuring equitable access for all Canadians. Endometrial or uterine cancer is the most common gynecologic cancer, globally increasing both in incidence and mortality, and on a trajectory to be the second most common cancer women, including gender diverse, trans, and non-binary individuals, are likely to develop in their lifetime. Now, despite these statistics, there's been little research attention or funding in endometrial cancer, receiving about a fifth of what prostate and breast cancer research receives. Beginning about 10 years ago, we recognized that the way endometrial cancers were being categorized and subsequently managed was not working. There was little consensus between expert pathologists in their diagnostic reporting, meaning that a patient could get a completely different diagnosis from 2 different pathologists, directing them, for example, to 6 months of radiation or chemotherapy or no treatment at all. And clearly, this way of managing was unacceptable, and our team worked to change this. So we identified key molecular features in endometrial tumors that could be determined by simple methods achievable in most hospitals already. And within 5 years, we created a system that could consistently classify tumors into 4 molecular subtypes, that could identify which patients were most likely to recur from their disease, could identify which patients were most likely to have inherited cancer syndrome, and determine which treatments work best. Our classification system was adopted by the World Health Organization in 2020 and immediately implemented into international treatment guidelines, and is now considered standard of care globally. But what's tremendously frustrating is that despite the international recognition, molecular classification is not uniformly available to patients across Canada. Even in British Columbia, where we developed this tool, it took 2 years for us to assure free testing for all endometrial cancer patients. And in Canada, we have centers where they may actually have to wait 8 to 10 weeks for their results. They may have to send their tissue out of province to get molecular testing. They may never even discuss molecular testing with their patients. Essentially, endometrial cancer has had one of the worst examples of healthcare inequities of any cancer, and our team's passionate about changing this. So my call to action is first to work to ensure that scientifically proven value-added initiatives in prevention, diagnosis, screening, and treatment in gynecologic cancers are available to all Canadians. This could be by supporting provinces, for example, to fund molecular testing for endometrial cancers across Canada. We must change the current reality in this country that where you are treated, or that how you are treated, depends on where you're diagnosed, and instead ensure equity for all. Second, I call for increased funding for gynecologic cancers, particularly funding for clinical trials and to support multidisciplinary team research, where it's been so successful in identifying important changes needed in clinical care. We've all witnessed what this government's rapid, impactful, successful communication access could do in the recent COVID crisis. This proves that federal government initiatives at health communication are possible and they can be effective. I look forward to seeing what we can achieve in these initiatives for the prevention and treatment of gynecologic cancers in Canada, and commit to working hard with you to create these changes. Thank you very much.
Thank you, Dr. McAlpine. Next, from Ovarian Cancer Canada, I understand you have a joint statement, Ms. Frionis and Madame Dunn. So the next 5 minutes is all yours.
Thank you, Mr. Chair, and thank you, honorable members. On behalf of Ovarian Cancer Canada and all Canadians affected by ovarian cancer, I want to thank the House of Commons Standing Committee on Health for conducting this important women's health study and for inviting us to appear as witnesses. 8 women a day are diagnosed with ovarian cancer in Canada, with 75% of those being diagnosed late stage. Ovarian cancer's 5-year survival rate is only 44%. 4 out of the 8 women diagnosed today will not be here in 5 years. There is no screening test. There is no definitive diagnostic test. There are few treatment options available, and women deserve better. My colleague and I will be highlighting for this committee 3 of the challenges and associated opportunities regarding this disease, from prevention to diagnosis to treatment. The most effective way to impact ovarian cancer incidence and outcomes now is through prevention. While some believe that the Pap test screens for ovarian cancer, this is not the case. There is no screening test for this disease. With an estimated 20 to 25% of ovarian cancers known to be hereditary, identifying those at risk through genetic testing and offering preventative or risk-reducing options will have a significant impact on saving lives now. Ovarian Cancer Canada and our partners have revealed gaps and inequities regarding access to genetic testing, including but not limited to regional variations in criteria and wait times, underrepresentation of individuals of Asian or Indigenous origin, and racialized and ethnic individuals being less likely to be referred for genetic testing and more likely to receive inconclusive genetic test results. We must maximize and optimize the identification of individuals at increased risk for ovarian cancer through timely and equitable access to genetic testing to stop ovarian cancer before it starts.
Le diagnostic opportun du cancer de l'ovaire passe d'abord.
The opportunistic diagnostic of ovarian cancer must go through these processes. It's difficult to identify ovarian cancer because its symptoms are vague. About 6.5 million Canadians do not have a family doctor, and a third have been looking for a family doctor for over a year. Furthermore, primary healthcare providers must be supported in recognizing symptoms and know which tests to order so that patients can be referred to a cancer center for a definitive diagnosis. For the timely diagnosis of ovarian cancer, Canadians must have access to primary care, and physicians and nurses must be supported in identifying and responding to ovarian cancer symptoms. With very few exceptions, available treatments have not changed significantly since the 1990s. Patients are treated with the same methods, surgery and chemotherapy. And unfortunately, these methods are not successful in most patients. Despite this, investments in ovarian cancer research has lagged well behind that of other cancers. Ovarian cancer is challenging and unique and has not seen the same advances as many other cancers. Traditional research funding mechanisms have failed to create significant progress in ovarian cancer. Therefore, Ovarian Cancer Canada and the ovarian cancer research community proposed a new model, one that allowed researchers to work collaboratively, continuously building on one another's progress, making advancements quicker and more efficiently. In 2019, the Canadian government took the bold step of entrusting Ovarian Cancer Canada with a $10 million investment towards this ovarian cancer research model.
$1 million may be a relatively small investment. It is enabling us to build a highly focused national research engine for ovarian cancer. We were also able to leverage the federal government's investment and attract more than $4.5 million in additional funding from research partners and 2 provincial governments, building a total of a $14.5 million research program. In just 5 years, Ovarian Cancer Canada has yielded an impressive return on the federal government's investment, fueling research in 6 provinces, resulting in 5 transformative clinical trials, 13 innovative preclinical studies, and 25 projects in ovarian cancer model development, allowing scientists to test and identify more novel treatments in new ways. In addition, we will soon be funding 2 translational clinical research projects aimed to improve and expand treatment options for women with ovarian cancer. We are now on the cusp of bringing new treatment strategies to Canada. For ovarian cancer to be preventable, curable, and ultimately eradicated, the federal government must continue and increase investment in innovative, highly focused, comprehensive national research into this disease. Ovarian Cancer Canada is leading the way in propelling crucial breakthroughs from the bench to the bedside faster. This work must be prioritized to change the trajectory of ovarian cancer in this country. Ovarian Cancer Canada applauds the government's commitment to women's health. Thank you.
Thank you both. And last but not least, Dr. Salvador. Welcome to the committee. You have the floor.
Thank you. Good afternoon, Mr. Chair, committee members, and fellow witnesses. I'm very honored to be here before you to present before this committee. I'm a practicing gynecologic oncologist at the Jewish General Hospital in Montreal, and I'm also the president-elect of the Society of Gynecologic Oncology of Canada, also called GOC. GOC is a nonprofit organization created 40 years ago as a forum for medical professionals to highlight issues in women's cancer care across Canada, to help correct the disparities in cancer care access, and to improve equity in research funding for new treatments. Historically, women's cancers have been orphaned from the traditional cancer care models. So in the 1970s, the gynecologic oncology subspecialty was created to care for women with cancers of the fallopian tube, ovary, uterus, cervix, vulva, and placenta. Unfortunately, these cancers long been, and often still are, deemed a women's issue. Funding for clinical care and research has not kept pace with other more common cancers such as colorectal, breast, or lung. And among all surgical cancer specialties, gynecologic oncology is uniquely comprehensive, including diagnosis, surgery, systemic treatment, surveillance, and palliative care, all done by one physician. GOC has identified 3 major concerns that need to be addressed swiftly to improve women's cancer care in Canada. Number 1, the backsliding of performance of our prevention of cervical cancer. Number 2, the rising incidence and death rate from endometrial cancer and the need for dedicated funding for endometrial cancer research. And number 3, the need for funding to train healthcare professionals dedicated to gynecologic oncologies as we start to form our multidisciplinary teams. First, a report was published in November 2023 by the Government of Canada with the Canadian Cancer Society on Canadian cancer statistics. It identified that cervical cancer as the fastest growing cancer in women, with incidence rising at a rate of 3.7% per year since 2015. Frankly, to me, this is shocking because women should have easy access to effective cervical cancer prevention strategies in Canada. Primary prevention via vaccination against the human papillomavirus, or HPV, is offered to school children in every province as well as women up to the age of 45, and has been available in Canada since the 1990s. Yet, there are decreasing vaccination uptake rates in our population. HPV is the primary cause of cervical cancer, as well as vulvar, anal, and throat cancer. GOC strongly recommends nationwide campaigns to increase the awareness of the burden of HPV and help increase those vaccination uptake rates. There's also secondary prevention via screening through HPV and Pap testing. Unfortunately, our most vulnerable populations are in locations that do not have an organized provincial-wide screening program yet, or easy access to healthcare professionals who offer screening, leading to disparities in identification and treatment of these precancerous cervical lesions. We need to support for better provincial-based screening programs for cervical cancer in areas that are not on track to reach our goal of cervical cancer elimination, either through improved access to healthcare professionals providing screening or through access to HPV self-testing as offered in some countries and is currently being highlighted in British Columbia. Second, the same cancer statistics report also identified a worrisome trend of increasing incidence and mortality of endometrial cancer. This can be attributed to both our aging population and increasing obesity rates in Canada, which are very strong risk factors for this cancer. We need to increase the numbers of funded gynecologic oncology positions in locations that have unequal access to the specialized care, as well as access to operating room facilities and robotic surgery, to accommodate the rising numbers of these women's cancers. To support gynecologic cancer research, GOC has created things called the Communities of Practice Forums. These forums have facilitated Canadian-based research teams, such as the ones run by Dr. McAlpine and her team, to collaborate nationally. However, dedicated research funding for endometrial cancer is rare, and we would benefit greatly from specifically earmarked allocations of funds. Finally, there is a need to increase funding to train other healthcare professionals in gynecologic cancers in the field of medical oncology, radiation oncology, family medicine, and nursing as we grow our multidisciplinary teams to provide holistic, patient-centered care. Having more of these specially trained care providers, especially in remote locations, will greatly improve the ability of our patients to receive ongoing care closer to home. GOC remains deeply committed to improving research opportunities, advocating for timely access to health services, and being a strong voice for women's cancer care in Canada. We look forward to working with the HESA Committee as well as other voices at the table to find solutions to these concerns. Thank you.
Thank you, Dr. Salvador. We'll now begin with rounds of questions, starting with the Conservatives for 6 minutes. Ms. Vecchio, please.
Thank you very much, Chair. And I would like to begin by thanking all of the women here that are here today. I assume, I'm Tanya specifically, I assume that you work with many of the doctors that we see on today's panel.
We do, absolutely.
Fantastic. And when this research dollars, you mentioned that you received $10 million and then increased by $4.5 million from leveraging that money. Would you be working with groups like these groups and these women to do that research?
Absolutely. We're very strong partners with GOC. And certainly we do some work with the Prevention Task Force with our friends on the screen there as well. So one of the things we're most proud of at Ovarian Cancer Canada is our ability to work across the country and really build these collaborative teams and participate in those as well.
Thanks so much. I want to go online to Dr. Jessica Alpine, and thank you very much for this information. You indicated that, molecular features, and when you're doing this, sometimes you don't need to have that radiation and that chemotherapy, which I think for many people who are suffering from cancer, that ends up being one of the most drastic pieces that they have to go through is how they're dealt with after surgery.
Yeah.
Can you share with me, first of all, when you're trying to detect these cancers, such as cervical cancers, things that get diagnosed later on, how long does it take to actually start diagnosing people and then getting into these types of programs where they might be able to look at things like molecular or this molecular piece that you're talking about?
Sure. Cervical cancer, first of all, is one that does have probably a 2-year lag period from precancer to advanced cancer, and with all those opportunities to either prevent with vaccination, screen, as Shannon Salvador mentioned, or to intervene and cure. So great opportunities there. Endometrial cancer that I was talking about is one that might present with spotting and very much depends on the molecular features of that tumor, whether this is a cancer that's confined to the uterus and cured by surgery alone, or is identified by that molecular feature to definitely need more treatment because very high risk of recurrence. So there are opportunities to intervene and cure with knowing that, and there's opportunities to spare treatment just in those 2 examples.
That's fantastic. Thank you so much. I just want to move over to Dr. Salvador. We're talking about genetic testing when we're looking at breast cancer, and we're talking a lot about the fact that, those high-risk groups, maybe here in Canada, we should be doing it 10 years earlier. I think those are some of the things that we heard, when the probability at 50 or 40. When it comes to cervical cancer, how do you ensure that genetic testing is done?
For cervix cancer itself, yeah. It's not genetically related, yeah.
Okay. Mm-hmm. Talking about some of the cancers that would be in the women's organs, what would be genetically seen? If we see that with breast, what would we see in those organs with reproduction organs?
So for the reproductive organs, actually it's ovarian cancer that one is the strongest. It's related to the BRCA mutations that we also see in breast cancer. And so this is where we actually have an opportunity to intercede for a lot of women if we know that they have family members who have a BRCA mutation. They can go ahead and get themselves tested. And again, this is opportunities to intercede earlier for women.
Are there any restrictions or timeframes? Like I said, with breast cancer, we saw that there was age verifications. What do we see when it comes to the ovarian cancer and timeframes?
So typically for ovarian cancer, we're usually asking women who have family members that they should probably go ahead and remove fallopian tubes and ovaries about 10 years, a minimum of 10 years before an incidental cancer in their family, or as soon as they are done childbearing. The reason we say that is because ovarian cancer is so difficult to treat, you really do not want to miss an opportunity to intercede and remove those. Endometrial cancer is also another cancer that can be genetically related through Lynch syndrome. People don't realize how strong of a connection that is. It's about 80% of Lynch syndrome family members can get endometrial cancer. Most people associate it with colon cancer, but it's actually just as strong for endometrial cancer.
A quick question on this, because I'm sure my time's running out quickly. Where would you get this type of screening? We know that to get screenings, we look a lot of times at larger centers. Canada is huge, and we're talking about equity for our patients. Where are these centers available, and how do people get these types of screening done or this care done?
Yeah, most cancer agencies in the individual provinces can run genetic testing within their own cancer agency. What we would really like to see is family physicians being educated and also having access and the ability to send, because that would be the best place to actually be able to go to say, I really need genetic testing. I have a family member who's been identified in another province. Can we please proceed with testing?
I assume there should be no cost to this testing. It is all covered by the provinces. Fantastic to hear that, too. I'm sorry, I keep on moving things over here. The HPV, you were talking about the HPV virus, the vaccine, and I know that in public schools they're offered, and you mentioned up to age 45. Is there a time in which a woman would be too old to have this? Like, for instance, if a 53-year-old woman presented herself, what would you say? Sure, give her the HPV. What would you do?
That's actually a very good question. We don't have research trials per se to say over the age of 45 do you actually mount an immune response, but I can definitely respond because I'm also the head of colposcopy in my hospital, that if I have a woman who is coming to me because she has a precancerous lesion due to an HPV virus, whether it be cervix or vulva, I absolutely offer them the HPV vaccine if they would like to receive it, no matter what their age.
So much. Thank you. I really appreciate that.
Thank you, Ms. Vecchio. Next for 6 minutes, Ms. Atman, please.
Chair, and thank you so much to our witnesses for being here. And I just want to highlight something that I think Dr. Salvador, you said, and it's that women's cancers have been orphaned from traditional models. And I mean, it should be no surprise to most of us sitting around this table why that would be. So I'm just really proud to be here with some other fellow women and our allies as well to really shine a light on women's health because it's been neglected for far too long. I'm going to focus a little bit on the cervical cancer piece because it's quite alarming to me that the rates are increasing. And what I see here, so we've got the report lists actually various factors associated with this increase. So you mentioned screening uptake, the vaccination piece, but there's also a higher prevalence of HPV due to changing sexual practices. Can you maybe expand on that a little bit? Like what underpins these increases?
I think one of the things that we're experiencing is that as people are becoming more sexually free and divorce rates are they being what they are, people are re-entering back into the sexual debut in an older generation. So these are women who may not have actually had the vaccine or had the opportunity to have the vaccine earlier. So it would be a good thing for women to be aware of. Up to the age of 45, you can get the vaccination, and we do recommend it. It is something that is definitely available for you if you wish to go to your family physician and get a prescription for.
Excellent. I did not know that, so that's amazing. So we know that all provinces and territories, they offer the school-based HPV vaccination programs. I remember that when I was in middle school. But it also indicates that there's a variance across provinces and territories. We've got numbers here from anywhere from 57% to 91%. It also reports a lack of disaggregated data on these rates. So why does the uptake of HPV vaccination vary across those provinces and territories?
I think it a bit has to do with the culture that may be present in each province and perhaps even the lack of education about HPV at this current time. When I was growing up and HPV was first discovered and then the vaccinations first came out, there was massive nationwide campaigns. I remember them when I was in my 20s going into my 30s as they were doing these. And what I've noticed is that there seems to be a lack of these campaigns nowadays. We have to keep in mind that every family who is making a decision on whether or not to vaccinate their child changes every 10 years. You're dealing with a new generation that's going into their childbearing years and making decisions about having children. So if we don't continue to carry forward with the education and offer these pertinent points of it's not just cervix, it's vulvar, anal, and throat. It's actually quite a large cancer burden when you look at it. We need to constantly stay on top of the educational component for our Canadian population.
Thank you. And how about that piece about the disaggregated data? How would that help us improve in informing our processes?
So I think it's trying to identify which provinces seem to be falling behind and trying to engage the population, because could it also be due to, again, maybe lack of family physicians and disparities in that, being able to provide the primary education even in the clinics as their children are growing up and going to see their pediatricians or their family physicians?
And as far as screening goes, I mean, most of us are familiar with the infamous Pap test, but I'm reading here that there's another way. So there's the HPV testing, which is compared to the Pap test. Can you explain what the differences might be?
Absolutely. So what a Pap test is looking for is the Pap test is already looking for changes that the HPV virus has caused in the cervix. So it is looking for an active lesion. What the HPV test for is it is looking for active virus. And so it is actually can be more specific and sensitive to be able to identify someone who has an active HPV virus. Not only that, but there are different subtypes of HPV. Some we know are more likely to cause cancers than other, more aggressive cancers. And we can subtype these now. So if we find out that someone has an HPV virus, and there are guidelines that were just published last year about this in combination with GOC, CPAC, and the Canadian Colposcopy Society. This was all put together through both recommendations Canada-wide for HPV testing, as well as what to do when someone has a positive HPV test.
And how many cervical screening programs currently use the HPV testing as a primary mode of screening?
Mm-hmm. In Canada, we are all doing a massive changeover right now. And so each province has a plan for rollout. It's supposed to be going on, and I do believe that various provinces are at various stages right now.
Very interesting. Maybe I'll go out to online, Dr. Henley. I'm really interested again in the disparities that exist across different populations. So I'm thinking specifically those that might be in rural or remote communities, Indigenous peoples, those with low income or socioeconomic backgrounds. So could you just describe how these barriers to accessing cancer care services for women present themselves and what we can do as a federal government to maybe implement some changes?
Yeah, I mean, I think you've heard from some of the other witnesses as well about these inequities. And unfortunately, we do see often in research that, where a woman lives dictates far too much in terms of what she gets with respect to cancer care. And this, goes from prevention all the way to molecular testing, such as Dr. McAlpine described, which then dictates treatment. So, there are really important inequities, and we do see that rural and remote communities often fall behind. Indigenous communities often fall behind. And so as researchers, we're working really hard to try and close many of these gaps, but it can be very challenging without collaboration with governments and other groups to help us address these.
Thank you, Dr. Hanley. Ms. Atwin. Suite, Madame Larouche, pour 6 minutes, s'il vous plaît.
Ms. LaRouche, 6 minutes. Thank you very much, Mr. Chair. I would like to join my colleagues in thanking our witnesses for being here today. We all know women that we can think of and dedicate this important work to. I would like to start with Ms. Henley. So you especially work on ovarian cancer, and you concentrate on the procedure where you remove the fallopian tubes. And in your document, you indicate that the treatments that are available for ovarian cancer have unfortunately not significantly changed since the 1990s. You also mentioned that the rate of survival hasn't improved in 50 years. So that's very sad. Could you explain the reasons behind the absence of improvement and progress in these areas?
Part of this is that ovarian cancer is just a really challenging disease. And so, I mentioned that there's been tremendous international effort to find an effective screening approach for ovarian cancer. So we've heard about the PAP test as a really effective screening approach for cervical cancer. So if women get the PAP test, Dr. McAlpine mentioned there's a long lag from the first sign that we see the precancerous lesion in the cervix to an active cancer. That does not appear to be true in ovarian cancer. So that has been very challenging, that we have not been able to find effective screening. And again, unfortunately, because symptoms often arise when the cancer is already in very advanced stages, we need treatments that are incredibly effective. And unfortunately, we have not been able to make a lot of progress on the treatment front either. And part of this is a result of, less funding dedicated to this kind of research, as I mentioned, and others have mentioned here as well. We have had a couple of breakthroughs in ovarian cancer. PARP inhibitors have been very important, and these tend to work best for the patients who have the BRCA mutations and have tumors that are homologous repair deficient. Unfortunately, that's just a subset of ovarian cancer patients. So there's still a very large group of patients that have no new effective treatments for their cancers. And there is a lot of work ongoing, and certainly Ovarian Cancer Canada has been a great leader in terms of funding this. And we've had lots of good federally funded research as well, but we need more. We need more work in this area. Thank you for the question.
I'd like to hear more from you about what was put forward in the 2019 budget, $10 million over 5 years. That was given to Ovarian Cancer Canada. You mentioned this served to fill the gaps that currently exist. And as you explained very well in your answer, it's a particularly challenging cancer. But you also I have a colleague who asked for details on the $10 million that could be used for research on new cures. Now, maybe if you could tell us a little bit more about the research projects that were paid for through that $10 million grant.
I would think that actually Tanya would probably have much better information about the specific projects if
Sure,
than I do.
Happy to jump in. As I mentioned, we were able to fund, we currently have 5 clinical trials ongoing right now, all testing new and novel treatments. So there is one that is launching very soon out of British Columbia that is going to actually challenge the way that a certain type of ovarian cancer is treated. So it'll be very interesting to see the results of that in giving PARP inhibitors first prior to surgery or any other type of treatment, along with a treatment regime of 3 different types of drugs. There's also been a really fantastic study in Montreal testing vaccines as treatments, and we're seeing real promise in that. So we've got the 5 clinical trials, but then we've also got those 13 preclinical studies that the ultimate goal in those is to lead to clinical trial and be able to bring more treatments to patients faster. And then, of course, we've got the kind of the core in the 25 projects based on model development, helping scientists understand how the disease is responding to different types of treatments and responses. So there is a lot of incredible work going on, but this has only been happening for 5 years, and that's a really short time in the span of research. And just to put it in context, 25 years ago, there were only 3 ovarian cancer scientists in all of Canada. Today, there are 250 plus. So we've got some ground to make up, but we're making it up, but it can only continue with the necessary funding in order to drive that forward.
Merci beaucoup.
Thank you.
Baron, please, for 6 minutes.
Thank you, Chair. I'm happy to be sitting in on this committee today, as this is a big opportunity to finally be talking about an issue that has not been prioritized for a long time. So for us to gather today to talk about women's health, specifically gynecological health, is a great day for me to be here. I have some questions that I'd like to go through. The first question that I have, Dr. Din, I believe it was you that had said that 6.5 Canadians do not have access to a family doctor across Canada. I'm wondering if you can really highlight the impacts on women to be able to access the care they need and also the preventative care that they need when it relates to gynecological health.
Je ne suis pas docteur, je veux juste clarifier.
I just want to clarify that I'm not a doctor. I'm the regional director for my association. If you don't mind, I will speak in French to represent the province of Quebec. So you're right. We talked about the context, the lack of access to family doctors, and the impact that can have on ovarian cancer. Women who receive a diagnosis without a family doctor often find themselves in an emergency context. They get a later diagnostic, and therefore the prognosis is not as good and their rate of survival is not as high. Beyond the issue of access, it's also important to talk about the awareness that family doctors have about ovarian cancer. The symptoms are vague and nonspecific. So once they recognize the symptoms, they also have to order the correct tests and therefore refer the patients to the right place.
Je ne peux pas demander les questions.
Yes, I won't ask the question in French, but I understood. Thank you.
My next question is to Dr. Hanley or perhaps Dr. McAlpine, whichever is best suited. We've been talking a lot today about the importance of national standards when it comes to women's access to health, also around the prevention and diagnosis. And I'm wondering what impacts you could foresee if there were stronger national standards in place, specifically how that would trickle into the care available in British Columbia. Are there any specific impacts that you can think of or benefits to having a national standard in place rather than a patchwork approach where the health care differs from province to province?
Can I go, Jillian, or would you like to go first?
You go ahead, and then I'll tack on after.
It's a wise question, and you've hit the nail on the head. I think it would go tremendously far. What you've heard about today from all of us, and again, it's lovely to be on this panel with so many people that we respect and are all working toward the same goals, is that, yeah, there's things that just make sense to everyone who I'm sure is in the room there, that are actually scientifically validated, that are things that resonate with patients, but are not universally implemented and needing that guidance. It's whether you call it knowledge translation and making sure people understand the value of it, whether you lead them with a carrot or a stick, or you set out guidelines that have to be followed. Those are what help enable things to happen. So I'm incredibly distressed by the fact that a patient that is 10-hour drive from me may have a different conversation with their physician than the patient around the corner. I think we do a very, very good job of centralized care in cancer centers, but there's still challenges. There's differences in communities' awareness of disease and how to treat it. And I think national guidelines would go tremendously far in helping to say, this is the gold standard. Let's all try to rise up to it.
Yeah, and I mean, I think the research that we've done nationally looking at differences in variation and uptake of opportunistic salpingectomy is really clear that if there were national standards and opportunistic salpingectomy was being done, at the same rate in other provinces in Canada that it's being done in BC, there are thousands of women who are going to get an ovarian cancer diagnosis that they did not need to get. They had an opportunity to have that cancer prevented and it was not taken. And that's just not acceptable. We don't, those are women, wives, mothers, sisters, friends that are going to die of this disease, and it's just not necessary.
Thank you. It looks like this will be my last question, so perhaps I'll keep it quick. But just following that, Dr. Hanley or Dr. McAlpine, there was some mention today about the HPV self-screening happening in British Columbia, and I'm wondering if you can provide some insights, being in British Columbia, around how that's going, any thoughts on how this might help to support increased screening for those who may not have access to health care for various reasons, and any other examples that we might see that are similar to this.
We're really excited and proud in British Columbia with the self-screening. As you can imagine, it helps reduce barriers of tremendous geographic distance, of a history of trauma. Those who have traditionally been not within the screening system, disproportionate number of minorities not getting screened, all of these opportunities are there, and it's been embraced incredibly well, and even by people who have not yet entered the screening age group, of how approachable and surmountable it seems now. I think we're getting there in some other disease sites as well. I'm proud to say we have free testing for molecular classification in Canada, and again, some of the other initiatives we've talked about, so that we are feeling that there's empowerment in a community 8 hours from Vancouver to try and do these things. I think that we have molecular stratification in other cancers that are underfunded, like vulvar cancer too, where we're getting to more precision tools. So I think we can get there. I think we just have to make sure it's across the whole country, and that there's enthusiasm and education for the value added.
Okay, thank you, Dr. McAlpine. Ms. Barron. Next, Ms. Goodridge, please, for 5 minutes.
Thank you, and I want to sincerely thank everyone for being part of this study and helping make life better for women and girls and just Canadians in general. In the back of our room here, I see a group of young women, and I was just wanting to perhaps open it up. Dr. Salvador, if you could give some advice to the young women at the back of the room and young women across Canada, what advice would you give them?
I think the most important thing that you can do is ensure that you're educated about your own health and what's available for you and what should be available for you. Because sometimes what you don't know is what you should know, right? It's what can I do to improve my health? What is up and coming in the world? So it's ensuring that you have done everything that you can to maximize your health, that your vaccinations are up to date, that when you're going to see a healthcare professional, that you have an opportunity to do some reading beforehand so that you can use the time to ask impertinent questions that are important for you and your family.
Wonderful, thank you. I appreciate that, and I think it's very good advice, and I hope all women take you up on that piece of information. In these conversations, we had the conversation around the BCRA gene, and it is relatively, there are screening tools in place that detect breast cancer. They're not perfect, and they're not great. They're not all great, and they're not super comfortable, but they exist. What exists as it currently stands to take women that are diagnosed with breast cancer and make sure that they have some kind of tests being done to ensure that the cancer doesn't metastasize to gynecological cancers? Or is anything happening in Canada that's similar to that?
Would you like me to? I can field that question. I actually sat in with a breast cancer group just at the beginning of the year as they are starting to really ramp up their BRCA testing programs. It's becoming much, much more permissible to get BRCA testing in breast cancer. It actually used to be fairly strict, and now they realize they should really be augmenting who can get tested. And so most programs are opening up in each province about really maximizing the testing. For breast cancers, they are often doing it with blood testing, but what's interesting is that for our ovarian cancers that are at risk, we actually do tumor testing. We test the tumor itself when we're doing their surgeries. And then once we know that a particular individual is testing positive for BRCA, whether it's in breast or in ovarian cancer, we've been working very hard to try and maximize reaching out to family members, making sure that they know to contact pertinent blood family members so that they can come in and also get testing as well, because the best thing we can do for anyone is prevention, by far.
No, I couldn't agree more. I've been reflecting this week. It's a tough week. 15 years ago, this week, I found out my mom had breast cancer, and about 11 months later, she unfortunately passed away, and she passed away at 49. So it was tough for our entire family, and it was because we lived in a rural, remote community that it prevented her from being able to have good screening early on, and things have improved substantially in that time frame, but this is something that an ounce of prevention is worth a pound of cure. And so I'm just wondering if anyone can perhaps share a little bit more about what wonderful things are happening, what best practices are happening across the country that we can look to when it comes to prevention, because that's ultimately going to be where we're going to find and save lives.
I think there is a lot of really important research happening with respect to BRCA and detecting those mutations earlier. So I know there are people who are part of the Gynecologic Cancer Initiative at BC who are looking at population-based testing. Certainly, we absolutely need to identify BRCA mutations as early as we possibly can in order to offer those people the prevention that we know works in both preventing breast cancers and preventing ovarian cancers. So, there's a lot of interesting research happening on how to get people the testing that they need as early as we possibly can in order to prevent, that those 20 to 25% of ovarian cancers in BRCA mutated people should be preventable if we detect those mutations earlier. And unfortunately, often these mutations are being detected at the time of cancer diagnosis. And so we're really working very hard on ways that we can offer this testing, to get those mutation results detected before any cancer has been diagnosed.
I want to thank you. That's
your time.
great information.
Yeah, thank you, Ms. Goodrich. Next, Ms. Cito, please, for 5 minutes.
Thank you, Mr. Chair. All the panel, a heartfelt thank you from all Canadians. Thank you, the work you are doing. And when we heard 8 women a day diagnosed with diagnosed with ovarian cancer, and 75% is on the 4th stage. Definitely, women deserve better. And I'm hearing that BRCA mutation, and if the PAP test is not, underlined, we can test that on if the BRCA mutation is the only cause. Do you think the guidelines need to be changed? My question is to Dr. McAlpine. Can you say something about that, like how we can protect women to go to the, who can survive, we can survive from the ovarian cancer, go on the 4th stage?
Yeah. So you're right. We don't have screening like we do for cervical cancer. We don't even have a heralding symptom like endometrial cancer where you might spot or bleed. And usually when you have symptoms with ovarian cancer, it's already at advanced stage. Very, very good international studies done, the US, the UK, Japan, none of which showed screening was had a large enough impact on identifying people. And that's really why we've shifted our energies into prevention. So we've talked a lot about BRCA. That's 20% of high-grade serous ovarian cancers. That leaves 80% of patients who don't have a family history, who are out in the community. They're what we call general risk. And that's where we think we need to actually put our energies and motivation in. And when those individuals are having a surgery in their abdomen, and we've moved even from focusing initially on gynecologic surgeries, you're getting a hysterectomy, but you are going to leave the tubes. Why don't you remove the tubes so that that cancer never develops? We're also now moving into the general surgery forum. You're getting a gallbladder surgery or a colorectal procedure. Your tubes are there. They're accessible. You have a skilled surgeon in the room. Can we remove those tubes so that that individual never, 15 years later, develops ovarian cancer? Otherwise, we're very challenged. We don't have a magic screening tool in our pocket.
Thank you. Ms.
Could I add one thing to that?
Sure,
Jessica did a wonderful job. But one thing I also wanted to mention is that we are now moving the research as well to trying to target people who are at higher than average lifetime risk for ovarian cancer, who might want to come in for a fallopian tube removal surgery in order to prevent. And that's not because they have a BRCA or another genetic mutation, but just because we're able to predict risk for ovarian cancer reasonably well and identify a subset of people who could benefit from fallopian tube removal to prevent their cancer.
Thank you.
Yeah.
And Ms. Ranis, your data suggests that only 35% of patients had prior knowledge of ovarian cancer. Majority either had a limited awareness or had never heard of it. What recommendation do you have to promote patient engagement and increase awareness about this disease to improve the chance to early detection?
Absolutely, and that is something we are obviously focused on as an organization, is improving that awareness, getting the message out, and working with partners in doing that. I think it's really important to elevate this particularly with family physicians when they're recognizing these symptoms. Again, we do recognize that when a patient is coming with symptoms, it is likely already late stage just because the nature of this disease. But it's really important that we keep this on as a focus and make sure that we are highlighting this for all Canadians. It's an important part of women's health. It's an important part of how it all fits in with our annual conversations with our doctors, and access to care is critical.
As a follow-up, research published in Advance in Cancer Research suggests that the incidence and burden of breast and ovarian cancer vary among racial groups. There's a higher incidence among white women, yet worse survival among Black women compared to other racialized or ethnic groups. Could you share your insights, on personalized treatment based on the demographic factor?
Yeah, I wish we had more insights, to be honest. I think we're still learning. Again, this is a relatively new area of research that we're trying to understand. When we as an organization reached out to our community, what we called our Every Woman study, we actually found our results came back very homogeneous. We had primarily white, well-educated women responding to our survey. So we're working hard as an organization to reach into communities. We do know that through a number of studies, there are certainly challenges with culturally safe care. So for instance, in terms of if ovarian cancer is suspected, what will happen in order to start the process of diagnosis is a pelvic exam, a transvaginal ultrasound, and a CA-125 blood test. So they're quite invasive procedures in order to move this forward, which particularly in the culturally safe care is a real challenge that women stay away from. We know that a number of women are diagnosed in the ER, which is not ideal as well. So there's lots that we still need to learn and understand, and we're working hard to do that, but there's still a lot of unknowns as well.
Ms. Frionis. Sorry, Dr. McAlpine, we're well past time for this round. Hopefully someone else will allocate some of their time to complete that topic. Suite, Madame Larouche pour 2 minutes.
Ms. LaRouche, 2.5 minutes. Thank you, Mr. Chair. This has already been touched on a little bit, what's happening internationally, but I'd like to ask you, Ms. Din, according to Canadian statistics in 2023, it's necessary to work harder when it comes to primary prevention. How do our initiatives here in Canada compare to initiatives that exist elsewhere? Unfortunately, I'm not the best person to answer the question. Is there another witness who might have more information about what's happening internationally?
Of treatment.
Écoutez, si je peux poursuivre.
Which interventions based on probative data are done elsewhere? Which ones could be used here in Canada, if anyone can answer that question?
I guess in some things, I would say for opportunistic self-injectomy, we're actually the global leaders on that. And the statistics and uptakes are fantastic on that. Prevention or screening is difficult anywhere in ovarian cancer. So I would say we all globally struggle. There's different models of population-based testing in other countries that I think are good examples that I hope we move toward, and risk-based assessment that Dr. Hanley touched on. I think some countries have better vaccination rates than us that could be learned from, and some worse. So I'll let others comment. I don't think there's one country as an example. I'd say that the defeating thing is that this lack of funding in gynecologic cancers is international, unfortunately.
Yeah, I mean, I agree with Jessica. I think, a lot, as I mentioned in my speaking notes, Canada has really led the world in a lot of gynecologic cancer research and a lot of effective prevention and diagnostic, endometrial cancer molecular classification. started here. Opportunistic salpingectomy started here. HPV-based screening, we're out ahead again. I think, in that sense, we're not missing anything that's been done in other countries, but sometimes other countries have been more effective in ensuring equitable uptake and access.
Okay. Thank you, Dr. Hanley. We're past time, but Dr. Salvador, I don't think your mic activated when you started to speak, so please complete your thought as concisely as possible.
Yeah, thank you. I think the issue is that other various countries might have more equal access across the entire country, whereas Canada has disparities depending on where you are. We're quite ahead in some locations and maybe not so much in others based on where you might be.
Thank you. Ms. Barron, please, for 2.5 minutes.
Thank you, Chair. Dr. Hanley, can you tell us a little bit more about the communication strategies that you were referencing in your opening statement?
I think I'm not an expert on how the federal government could communicate, but I think we have seen examples in the past of the federal government, helping get messages about health and about wellness effectively out to all Canadians. And I think it would be incredibly powerful to use that as a way to get messages about gynecologic cancer, to ensure that Canadians are aware of prevention opportunities like opportunistic salpingectomy, to ensure that all Canadians are aware that HPV-based self-screening is available to them, that, it's not available everywhere yet, but it soon will be. And when that is the case, ensuring that all Canadians know that they can order a test, a kit to their house, do this in the comfort of their own home when they want to, and that this is more effective than Pap testing, in terms of screening for cervical cancer. I think there's a tremendous opportunity to communicate these really important messages to Canadians.
Thank you. And Dr. Briones, can you tell us a little bit more about the importance of appropriate training and professional development to continue to have practitioners that have the most up-to-date information, are able to work together, are able to ensure the information is transferred to new practitioners coming into the field and so on, and how that all relates to us moving forward in a more effective manner?
I will certainly share a brief comment referencing. I am also not a doctor, so I might actually ask Dr. Salvador to comment on this. But I would say this: we do know, particularly with family physicians, many family physicians will never see a case of ovarian cancer in their life. So we've worked as an organization to create some connections between upcoming med students and patients that are living with the disease. But it's not because they don't see it that often. It's not something that's necessarily easy to detect. But I want to allow the expert, perhaps, to comment on that, if I may.
So when it comes to training gynecologic oncologists, quite frankly, we are an incredibly tight community. There are not many of us in Canada. I don't think people quite understand. We're talking about 250 gynecologic oncologists serving the entire population of Canada. And we're training probably about anywhere from 5 to 10 per year. I know all of them. Personally, it's they trained me. I've gone on to train the next generations of groups. So when we're working now and the field is becoming more and more complex, this is where we need the help, which traditionally hasn't happened before, of bringing medical oncologists and more nursing staff, family physicians into our field of practice. And we have some very dedicated medical oncologists who've been with us for the last 40 years, but trying to get the next generation of medical oncologists to become interested in gyne-onc, which has sometimes been deemed, not quite as exciting because maybe they're not doing the most exciting treatments that they might see while they're treating their lung, colon cancers, melanomas, and things like that. But we are now breaking into that where we really need our colleagues' assistance to come and join us here. And so when it comes to training, the gyne-onc group is very tight with themselves, but we need to start bringing in medical oncologists, family physicians, and nurses to join our team.
Thank you, Dr. Salvador. Next, Dr. Ellis, please, for 5 minutes.
Thank you very much, Chair, and thanks everybody for being here. I had a couple of questions around potential years of life lost. And for me, that always had significant meaning as a family physician. Often cancers we talk about happen in older folks, but specifically when you talk, aside from endometrial cancer, of course, when you talk about gynecological cancers, it has a significant impact on mainly young and middle-aged women. So Dr. Salvador, I don't know if you had some comments around that.
Cervix cancer has some of the most potentially large impacts on that. Most women who are diagnosed with a cervix cancer, it's happening usually between the ages of 45 to 55 at the prime of women's lives when they're also launching their children, highlighting their careers, also trying to take care of older family members, and then they themselves are struck down with what can be quite a devastating cancer. So in terms of cervix cancer, it can be really quite dramatic. For any of our genetic-related cancers, that is typically also in young women in their mid-40s to early 50s, both for ovarian and endometrial cancer. But as our women's population are living longer and longer, we have to acknowledge that the average age of that a woman could live to in Canada is well into their late 80s and will probably soon be into their 90s. They're living well and living healthy into their 70s and 80s. And so when you ask about lives lost, well, these are healthy women with no other medical issues that are then struck down with an ovarian cancer that, yes, before, okay, well, when the lifespan was maybe in your late 70s and early 80s and they're getting their cancers at that time, all right. But now we're talking about women who had a potential to live for another 10, 15, 20 years even.
Thank you very much for that. One of the other questions is around the salpingectomy with, for instance, with a vaginal hysterectomy. And I apologize because I forget who's the expert in robotic surgery. So, okay, that's you. Okay, good. Well, I'm sorry to pick on you again. You know, certainly I practiced in Nova Scotia, and, you know, we have a very robust gynecological oncology program. It's very centralized. The difficulty, of course, is travel. Certainly in small rural hospitals, we're not seeing robotic surgery other than for cholecystectomies, really basically is where we're at, and appendectomies maybe, depending on who's working. But the difficulty is talking about salpingectomies, for instance, with vaginal hysterectomies, and does that create a bigger issue for local gynecologists to be able to do that?
Actually, no. The nice thing about a salpingectomy, actually, this is definitely Dr. McAlpine can speak to this as well, as they did large educational programs on this. It's actually a fairly easy thing to add to a surgery that's being done anywhere near the pelvis. That's why they're branching out into their colorectal and general surgery teams, because if you're there to take out an appendix, it's a pretty easy thing to also pop out a couple of fallopian tubes while you're down there. And even at the time of doing a vaginal hysterectomy, it's actually fairly easy to move the fallopian tubes into the vagina to be able to remove them safely and allow the ovaries to stay behind.
Thank you for that. It's for any of you who've seen it, it's not really that easy. But anyway, I was not a gynecological surgeon. Anyway, that's a whole other story. One of the other issues, of course, across this great country, and whoever feels like answering it, feel free, is Pap test screening. First of all, you have the issues, of course, with access and, you know, for instance, you know, if you're a female, do you want to see a male physician like myself? Those things present some difficulty in creative answers. But it's the recall process that worries me the most. First of all, we don't know who's actually getting a Pap test with respect to who should be getting one. And then, of course, once you have a Pap test, you never get the answer back, and you have to rely on the physician to say this is this is good or bad or indifferent, and you need a recall, et cetera. So, you know, even if we do create a process with HPV testing at home, the recall process is something that we would have to really look into. Has anybody put any thought into that? I have some ideas, but if you got a better one, I'd love to hear it.
I can maybe comment a little bit as we've rolled this out in British Columbia with self-screening. And we also have a crisis mentioned by many of the members already about a shortage of family physicians, that there's clauses in there of how to deal with a result if you don't have a family physician. How do you deal with result if you do and engage them? And actually piggybacking onto the same system of vaccine notification and availability that we used for COVID in the provincial program. So it comes to their phone and it comes to an app of being able to inform them. Or it also is sent to their physicians if they have one. So I'm encouraged because right now, even the system before from a couple of months ago became increasingly challenging if we didn't have a primary care physician. And I think that we have the tools to do this and to do this well.
Thank you, Dr. McAlpine and Dr. Ellis. Next, we're going to go to Dr. O'Hanley. Dr. Hanley, the one from Yukon, for 5 minutes.
Finally, I get to speak. Well, maybe I'll start with Dr. Hanley, and rather than engage on what common relatives we might have, I just wanted to ask you about you mentioned how effective self-injectomy is. You referred to a study. You don't give a lot of detail for good reasons, but I just wonder if you could give an overview of what we have learned about the actual effectiveness, and you know how many, what's the numbers needed, how many do you have to do to have a positive outcome? Where are we going with the literature to really support the expansion of this technique?
Yeah, so there should be a really easy answer to this question, and unfortunately there's not. And that's partly because, we're still in fairly early stages of the research. As you may be aware, the average age of diagnosis for ovarian cancer is 61. And we actually do these opportunistic self-injectomies on people. Usually the average age is in their early 40s. So we haven't had all the follow-up time that we need to really answer that question. But our 2022 article in JAMA Network Open, which was the first prospective study of opportunistic self-injectomy, which is done for the purpose of ovarian cancer prevention, which is important because that means the surgeon's removing the entire fimbriated end of that fallopian tube to really reduce the risk. We saw 0 high-grade serous cancers in the approximately 26,000 people who had an opportunistic self-injectomy. And this was statistically significantly lower than the number that we would have expected to see if the cancers had been arising at the same rate as they were in the control groups, which are the people who had hysterectomy alone or tubal ligation. We haven't had enough follow-up time to give that specific number needed to treat, but we have a lot of preliminary evidence that suggests that opportunistic self-injectomy is going to be very effective at reducing risk for high-grade serous ovarian cancers.
Thank you. And I guess maybe a common theme is around implementation. Like how do we move forward and make things more uniform where we see successes? I'm equally, I don't know if it's shocked, but certainly it's quite alarming, again, to see the recent rise in cervical cancer incidence when this is probably the most preventable cancer that there is. So there seems to be a bit of a disconnect here. And Dr. Salvador, I think you were talking about this is a demographic, sort of almost like an older demographic who would not have been in the vaccine cohort. So just to dig a bit more into that, are we seeing this in peer countries? I just heard, I think it was Dr. Ogilvie, Dr. Gina Ogilvie on the radio just the other day talking about how amazing the Australian vaccine cohort results are, and they are on track for elimination. But at the same time, we're seeing this kind of separate phenomenon in the older, presumably the older demographic. Maybe you can unpack that a little more for us.
I think the thing that also disturbed me the most when that data came out is the data collection ends at 2019. And we all know what happened in 2020 and the years thereafter. So if we thought there was a problem with screening going up to 2019, because I think that's where it probably is the majority of the issue, is that women were not getting screened, were being screened late. We're going to have a major uptake, I think, once we hit and get the 2020 through the 2024 data now, because the screening drastically dropped off, and it hasn't gone back up to the levels that were at it before. Because of lack of access now. It was people were not being screened during the COVID years, and then were, even when screening was restarted, people were not having access to locations to get screened. So I think we're actually on track to get another big shock with the next collection of data when it comes through, unfortunately. So
I'll have to cut you off because I'm almost finished my time, but I think it maybe lead into the segue where Dr. Ellis was asking about, self-testing and how we, I guess, is there an opportunity here that we can kind of leapfrog into expanding and widely implementing HPV self-testing as maybe a way to get this back on track?
I absolutely think so. That's actually one of my desired mandates when I take over as president of GOC, is that I want to get all the partners at the table to talk about how do we bring HPV self-testing to this entire country. As you mentioned, it really requires a strong provincial program of database collection, of which, again, one of the strongest in the country is British Columbia. They know who's been tested, who hasn't been tested, when they were last tested. They send recall letters to remind people it's time for testing. The provinces that are looking to create a program, if they don't have one, should really use it as a model to move forward. And I agree completely that adding HPV self-testing and going in that direction is a strong recommendation.
Thank you, Dr. Salvador. Next, Dr. Kitchen, please, for 5 minutes.
Thank you, Chair, and thank you all for being here. It's a great pleasure to have you here, and the tremendous amount of information that you have provided for Canadians that are watching and that we will see in the report, so it's greatly appreciated. I come from Saskatchewan, and very rural Saskatchewan, and my riding is 43,000 square kilometers, and yet it's not the biggest one yet. I mean, I had many patients that travel quite distances to come. And the unfortunate part for us in the southeast corner of Saskatchewan is we don't have a lot of family practitioners that have the skill and the knowledge in a gynecological area. And so I think a lot of things get missed. Your comment, Dr. Salvador, about the self-screening, I think is tremendous, because I think when we talk about HPV self-screening, I would say to you, I would bet that maybe only 5% of the population knows it even exists. So I guess to further emphasize that, though, the cost of that, what sort of cost is that going to be?
That's one of the things we've debated in how do you create a program, because do you create an opt-in program or do you create an opt-out program, right? As you can imagine, an opt-out program would be incredibly expensive. That's now mailing a self-testing kit to every person who is available and then seeing who mails it back. I don't know if cost analysis that would actually work out. I think if you're going for something like an HPV self-testing program, you'd have to go for letters of introduction followed by an opt-in to then send a test to someone who's requested. You're then more likely to actually get that test back to be able to do that. Because definitely health costs in terms of those types of programs are a huge consideration.
And would you see this as a national or more of a provincial aspect? Because there are those huge challenges.
That is obviously a very huge challenge. Currently, right now, this obviously falls into each province responsibility to create their own program. The big issue, again, with just provincial is that people move. And so when you have someone who's crossing a provincial border, it's a little bit like starting all over again in terms of their medical health. You may not have access to records of things that was previously done. You can't bring them across a provincial border without the patient physically bringing them themselves. So in the best screening program, you would have a national program where access to patient information about previous screen is available for all people across the country.
Thank you. And I know, as you're probably well aware, which the general public isn't well aware, the reality is that HPV has been going on back in Neanderthal times. And yet we first found out about HPV, I believe, in 1949 by the Strauss et al. And the reality was that was done on an electron microscope. Now, granted, when I started practice, electron microscope was the testing device of the day. But the reality is that we've seen it out there. You know, the vaccine was basically founded in 2008. And again, it's a public knowledge, I think, that we need to get out to Canadians to truly understand the value. The challenge we have, too, though, is the cost of that HPV vaccine. Because there's a perception out there that the cost of it is free when it isn't. And in some cases, they're talking $300, $400, $500 for people who just can't afford it. Any thoughts on that?
That's definitely a challenge. Right now, we are currently vaccinating majority across the province with our children being vaccinated with something called Gardasil 9, protects against 9 types of HPV. They get 2 vaccinations being done 6 months apart. Once someone is out of that young children program, then the cost is falling upon the individual to then pay for it. And once you're past the age of 18, they kind of set it as a bit of an arbitrary marker, you no longer amount the same immune response, so it requires 3 vaccinations. That's where this does start approaching $600. So for a person who has not had the opportunity to be vaccinated as a child, that's a shame.
Thank you. And I'll touch briefly, the reality is that I don't have much time, but one of my concerns is when we look at the rural practitioners, how do we educate and what suggestions would you have that we can put out there for our future primary care practitioners such they're educated enough to understand the steps that need to move? They see it in school, but oftentimes if it doesn't become part of their practice, it often gets missed. And I just comments on that.
One of the groups that we are bringing to the table are the Family Med Practitioner National Societies, so that they can help distribute the information to their bodies as well. Obviously, these physicians have to go through continuous medical education. We all do. It's a requirement as part of our practice. So whenever we get these new information or have new things to inform family physicians and help the education, we reach out to their conferences. We all do this, and we send experts to go to their conferences and speak and allow the dissemination of information in each of the provinces.
Thank you, Dr. Salvador.
Yeah, I would add across each initiative just very quickly that for each initiative we have toolkits and education things that we're trying to build for family practitioners, general gynecologists, not just the cancer specialists in the room. Those are things that probably could use better, funding and support, but those are priorities, and I agree, incredibly important, and that's what we're working toward.
Thank you, Dr. McAlpine. Next, Dr. Pawlowski, please, for 5 minutes.
If I could ask a kind of preemptive question, because I'm going to ask a whole bunch of other ones. The Canada Task Force on Preventative Health, we've heard quite a bit about them and their recommendations with breast cancer. How involved are they in making recommendations on other kind of gynecological screening and or treatment like the salpingectomies? Maybe I could ask Dr. Salvador, since you cover all these. And you're here.
In terms of salpingectomy, actually, Dr. McAlpine, did they actually come out with a statement directly on it?
Not that I'm aware of. Dr. Hanley?
No.
That's kind of interesting because and certainly we've heard on the breast cancer study what questions about their recommendations. So I think that's interesting. Maybe can I go to Dr. Hanley, and the real not Dr. Hanley, not the useless guy sitting beside me. No, I think it was you that said that was it a JAMA study on salpingectomies, and there was 26,000 women who had salpingectomies, and none of them got ovarian cancer. And then you didn't mention how many in the control group. I assume there was a control group of 26,000. How many of them, and was that statistically significant?
Yeah, so the control group, we included basically what the surgeries that women would have gotten prior to the recommendation that salpingectomy be included. So those were women who had hysterectomy alone, so their fallopian tubes got left behind, or women who had tubal ligations, so their fallopian tubes were tied rather than removed. That was our control group. There was 32,000 of them. There was 15 cancers in that group. So again, because these women are still quite young, this is not reflective of the number of cancers we expect to prevent. The average age in these groups was 42 in the salpingectomy group and 41 in the other group. So we're nowhere near with the follow-up that we have the average age of diagnosis of ovarian cancer, but we've already seen this statistically significant difference in these groups at this very early stage. So that's very promising in terms of the risk reduction we can expect.
Now, correct me if I'm wrong, but I actually, having worked quite a few years in developing countries where I did surgery and did tubal ligations and operated on a fair number of ectopics. Am I right? But it's not technically very much more difficult to just take out the whole tube. Is it like an extra tie, or how much more work is it?
Yeah, on average, we did a study on average adds about 8 minutes, and it's minimal blood loss. And to the developing country point, my resident just came back from Kenya where they're doing opportunistic salpingectomy.
Yeah, and in our colorectal surgery trial, the colorectal surgeons, the average additional time in the OR has been 4.5 minutes to remove the fallopian tubes. So it's not difficult, and it doesn't take long.
So my question is, or what's the hesitancy or what's the problem in getting greater uptake? Because I think you said something about, now, what was the number? 80,000 people per year get tubal ligations? And if those were all salpingectomies, you figured it would decrease the number of cases of ovarian cancer by 1,000? Or can you just repeat those numbers?
Yeah, so that was a study we did looking at hysterectomies and tubal sterilizations across Canada. And what we found was between 2017 and 2020, 80,000 Canadians received a tubal ligation or a hysterectomy without a salpingectomy. So they missed the opportunity to have their fallopian tubes removed. And this is this is well into the time where we were recommending opportunistic salpingectomy. The SOGC formally recommended it in 2015. That will translate into a possible 1,000 future cases of ovarian cancer that could have been prevented if that opportunity had been taken to remove those fallopian tubes.
Now, why isn't there greater uptake of surgeons doing a salpingectomy instead of doing a tubal ligation? And maybe I could get several people to comment. Is it the lack of evidence, or what is it? Because it doesn't seem like it takes much more time at all. Maybe I could start with you, Dr. Hanley, and then maybe I could ask a couple of the other gynecological surgeons.
Yeah, I think that there was some hesitancy. There was some concern around possible additional complications. I think the research has really addressed those and shown that that is not a risk. I do think there were some surgeons who were waiting to see the evidence of effectiveness. And I think now we have evidence of effectiveness. And so I hope that will change minds. And then I think that there's just some degree to which the message still has not reached all surgeons, which is, unfortunate and something that we're trying very hard to change. So we've been speaking with all the provinces where rates have been lower.
Thank you, Dr.
Yeah, I would
Hanley.
say knowledge translation. And just again, if you're not talking about it and your patient's not asking about it and your residents aren't bugging you to do it, it's easier just not to do. And I think that speaks to some themes you've heard today of that. If there's good science, you still need to talk about it and bring it to the places that maybe are too busy to go to that national meeting or haven't been partaking in CME, and how can we notify them and keep people educated.
Thank you, Dr. McAlpine. Dr. Salvador, I'll get you to hold that thought. Dr. Poloski's actually going to get another turn, and he probably will give you some time then. Next is c'est Madame Larouche pour 2 minutes.
Ms. LaRouche, 2.5 minutes. Thank you very much, Mr. Chair. Ms. Salvador. Dr. Salvador, you talked about vaccination. I'd like to hear from other witnesses who have something to say about vaccination and cervical cancer, because the World Health Organization called for the eradication of cervical cancer. Is Canada on track to meet those objectives by 2030?
Question. So, under the CPAC, there is a very distinct guide and layout on Canadian goals on how to eliminate cervical cancer and meet our World Health Organization. And currently, if you go through year by year, because this was first created again as COVID kind of struck, we've fallen behind on those goals that were laid out in that very distinct and quite comprehensive document. The vaccination rate is one of the biggest concerns that they highlighted in that layout. And currently, right now, the main part of that goal is to get our vaccination rate back up to over 90% by the end of this decade, and that is not on track right now for us to be doing that. There's also parts about being screened, again, 90% being screened for HPV. We've fallen quite a ways behind there. And also for access to colposcopy. Now, that is the one thing that we are maintaining, but that's also because we're not seeing the numbers that we were expecting to see. And the actual colposcopy clinics are meeting their goals on being able to see people very quickly once they're diagnosed with their HPV. So for us to be able to meet that goal with the WHO, which is in 2040, we have a lot of work to do. I think Canada can still do it. We just require us to really get back on track and meet together as the invested parties at the table to look at that document again and meet these goals that we've already set as a nation.
Merci, Madame Larouche. Dr. Salvador. Next, Ms. Barron, please, for 2.5 minutes.
Thank you. Forgot to set my timer on here. That's okay. I'll just trust my own judgment on it. Dr. Salvador, in your opening comments, amongst other things, you had mentioned, and I wrote down the words of what you said. You wrote down, you said that there is a backsliding of prevention. And I'm wondering if you can expand a little bit on what you meant by that.
That is related to the cervix cancer issues. If you look at the numbers pre-2015, our cervical cancer rate was actually dropping very nicely. It was going down right on track the way that we were expecting it. And if you look at the projected numbers that were going out from the previous cancer report, they were expecting it to continue to drop. And that's why this report coming out in 2023, just a few months ago, was quite eye-opening to all of us that has not happened. So that is where I see the backsliding, and we need to pay attention again. I think we've kind of got a little bit lax, thinking that, okay, well, as we all commented, this is the easiest, most preventable cancer. We have a vaccination, and we have a long, long prodromal period in which we can identify people with precancer lesions. So I think it's just a matter of telling ourselves to wake up again, that it does require all of us to get to re-educate ourselves.
Thank you. And another thing that I'm curious if you can expand on, Dr. Salvador, is you were talking about the costs associated with the HPV vaccination after 18. Now, I believe what you'd said is that there is a cost for those 18 and older. And I'm wondering if you can provide some reflections on the impacts of these costs and the ripple effects of people having to pay for these vaccinations once they are over 18 years of age.
Mm-hmm. So if someone has not gotten vaccinated as a child, then once they're past the age of 18, they incur those costs on themselves in most of our provinces. There are some provinces that will help cover the vaccination for people who have already been diagnosed with a lesion. that's a little bit of a backstep just because they have been diagnosed with a lesion. You don't want them to miss the boat. The hope is they can get vaccinated before that case, but definitely offer it to everyone. For some of my women that I've met in the colposcopy clinic, it is a detriment to being vaccinated. They cannot afford it. We discuss it. I even have a very dedicated nurse who went and negotiated with our pharmacy group there to actually offer the vaccination at a reduced cost for them, because this is how much we valued it and thought it was so important to get done. But it is definitely preventing some women from being able to get vaccinated themselves.
Thank you, Dr. Salvador. Next, Dr. Ellis, please, for 5 minutes.
Thank you very much, Chair. You know, I don't think I'm belaboring this, but I do believe that this novel screening program is the future and where we need to go. And you know, I think we need to be clear to Canadians a couple of things. One is those routine immunizations; they need to get them. We're falling behind on everything. I think that's incredibly important. These are well-proven immunizations, so people, and they work. I think that's one important point. The second point is what does this program act? What would it look like? What would the best program look like if you could walk us through the steps in the sense, okay, you do self-screening, assume you do a swab at home, you send it in, then what? If it's positive, do you end up going directly to colposcopy? Do you have a pap test after that? And then maybe just a very brief outline if you could.
Yeah, absolutely. So for HPV testing, we are currently going to be recommending that women get swabbed once every 5 years in however method that they do. That's different than pap testing. It has to be more frequent at that point in time. If someone has a negative, great. Next time they need to get swabbed is in 5 years. If someone has a positive, we do the subtyping on it. If it's one of the higher risk subtypes, the 16 and 18, those are the high risk subtypes, then those are direct to colposcopy. And that is something that if you had a national program that was reviewing these, you could offer, if the patient wants to discuss with a local healthcare professional who would have to be employed by the province to go and get that done if they've done self-testing, versus even offering them virtual consult about that. They don't necessarily have to physically come in and could be offered virtual consult. As we've seen with COVID, we managed quite nicely with a lot of virtual consults. To give them the information and then direct them to the nearest colposcopy center, which could, again, just be handled through paper means of getting the consult across, and they're seen in colpo and then dealt with via the guidelines on what we recommend. If it's someone who has one of the other subtypes that can be high risk, at that point in time, we do offer reflex pap testing to see if there's any development of a lesion. If someone has had the HPV test in a clinician's office, it's often something called liquid base, which means they can automatically do that cytology, the pap test, on the liquid. That does not require someone to come in. However, if someone is self-testing at home, that is actually a dry swab. It is a different type of swab. They would require then a visit to come in. So each of those things need to be addressed in your area wherever you are setting this up to make sure that all of those different components are covered.
Great. Thank you very much. And I do apologize, but there is one thing that I would like, and hopefully we can take care of it very simply. It's seeking the unanimous consent, Chair, of the committee that given the recent overdose crisis in Belleville, Ontario, which had to declare a state of emergency after responding to 23 overdose incidents in the span of less than 2 days, the committee calls the Mayor of Belleville, Neil Ellis, Belleville Chief of Police Mike Callahan, and other experts to appear before the committee at the earliest convenience, no later than February 23rd, and express its concern to the House. Again, I apologize for that, but it needed to be said. It's an urgent situation, so thank you all.
So I presume that you're putting that on notice?
That is correct.
Okay, thank you.
I'm seeking unanimous consent for that, actually, Chair.
Well, I mean, if there's unanimous consent, we can do anything by unanimous consent, but
Yes.
otherwise the motion hasn't been given 2 days' notice. So
That is correct.
Absent unanimous consent, it would be out of order. Do we have
correct.
unanimous consent to adopt the motion presented by Dr. Ellis? We do not. Dr. Ellis, you still have about a minute and a half.
Great, thank you very much. So when we begin to look at systems here. Obviously, we know that there's incredible ideas that exist, and you know, this is something that I think all of us around the table suffer with, is that provinces are practicing in silos, and is there anybody around the table who has an idea of how do we get this information out, and how do we, because we don't have a lot of levers here at the federal level, but how do we encourage provinces to say, hey, let's work together on this, let's make it happen? I'm happy to hear that, because that presents a significant difficulty. Don't everybody raise their hand at once. I get that.
I think it's a matter of knowing the champions in each province. I collect names. I know people, yeah, and it's a big part of what I do, is making sure I know who the champion is in each of the provinces to reach out, because they know the issues in their province and they can bring it forward to the tables. That is how you have to break down silos.
Excellent. Thank you, Chair.
Thank you, Dr. Ellis. And the last round of questions for this panel will be posed by Dr. Pawlowski for the next 5 minutes.
Start with Dr. Salvador, since you didn't really address this question on ovarian cancer and salpingectomies. Should the Canada Task Force on Preventative Health make a recommendation with respect to this? How much would this help to address the fact that people aren't doing them like perhaps they ought to be?
I think it would absolutely be useful. Our society, as we said, the Society of Obstetrics and Gynecologists, the societies in the United States, most of the societies in Europe, they've all come forward to make statements saying that we should be doing this. So having the Canadian Task Force also come forward would be useful.
Dr. Hanley and McAlpine, just for the record, since we'll go into our recommendations, do you recommend the same thing?
Yes. Yes.
Okay, thank you. So I wanted then to switch to cervical cancer and our backsliding on this issue. I guess, and I hate to get it, and believe it or not, I hate to actually get into the politics of this, but why are we seeing decreased vaccination rates? And maybe I'll just limit to one person, Dr. Salvador, since you're kind of the generic expert on and you're the lead of Ontario with the Canadian Gynecological Cancer Association.
I think a lot of it has to do with how strong the provincial message has been about cervical cancer. When you have a province that has a very strong database, and so mums are watching themselves get called, come and get your pap test, come for this, come for this, come for this, and then themselves, if they've ever had to go for a colposcopy, it's really on their forefront and on their brain when they're making decisions about vaccinating their own children. So if you have a very strong, robust message coming from your province that this is an important issue and to get screened, any woman in the room knows how it is to get screened. It's not pleasant, and so if they can prevent that for their own children, they would absolutely go for it.
Do you want to just briefly mention the value of vaccinating boys for HPV? I have two teenage boys, and when I first kind of read their little request for consent, I kind of, what, boys? But I assume it relates to herd immunity, and do you want to just kind of basically say, like, how many potential deaths are you saving by vaccinating boys as well?
It's actually related to two things. It's not just related to herd immunity, which is obviously beneficial. You're preventing the other cancers too. Men have a high risk for anal cancer and throat cancer. And yes, they don't come until much later in life. These are usually things that are now happening in their 60s and 70s. But if you ask any ears, nose, throat doctor now, any of the ENTs, because smoking has dropped so significantly, they're no longer seeing throat cancer due to smoking causes. All of them are HPV related now.
How much time do I have left?
Minute and a half.
Okay, let me get to my moonshot question. I think it was Dr. Hanley said something about a goal of by 50% decreasing cancer deaths by 2035. Maybe you could just reiterate that for me, because I didn't really hear it. And let me say that President Biden has, in one of their moonshots, endeavored to decrease the number of cancer deaths in the United States by 50%. What is it? By 4 million by 2047, which is 25 years from now. Should Canada be making a similar effort to decrease cancer deaths? Anyhow, let me start with Dr. Hanley, and then maybe I'll move it on to some of the other people in the room. Thanks.
Yeah, so at the Gynecologic Cancer Initiative in British Columbia, where we're working across disease sites and across institutions and across disciplines to address all gynecologic cancers, because we can learn from each other, as I think you've seen here today. We have a goal to reduce death and suffering from gynecologic cancer by 50% by 2034. And we put this in place in 2019, and this includes prevention of cervical, ovarian. It includes improving treatments for endometrial cancer. It includes improving survivorship for those living with and beyond gynecologic cancer. So we have a very complex plan that we'd be very happy to share with you if you want to come and visit us in BC.
That would be great. And then quickly, Dr. McAlpine and the others here in the room, thanks. And you better make it quick because we're running out of time.
Yeah, nothing to add over what Jillian said, except for to say that if the science and the initiatives are there, we need to use it and
people in the room.
Perfect. Thank you very much. And that concludes the rounds of questions for this panel, but it doesn't conclude our meeting, so colleagues, don't run away. We still have 30 minutes of in-camera business to deal with. But to our expert witnesses before us today, thank you for being with us. I expect that you're incredibly busy people. We certainly appreciate the professional and patient way that you provided such comprehensive answers. They will be of great value to us in this study. So thanks what you do for your patients, and thanks for being with us today. We're going to suspend while we switch over to in-camera and allow our guests to take their leave. So we're suspended for 5 minutes.